Bismillahirrahmanirrahim. The quote of the day is inner experience is the only source of human knowledge by Dr. Allama Muhammad Iqbal. Today we will discuss about the critical appraisal of the article whose title is Quality of Life and Factors Affecting It in Patients with Alzheimer's Disease, a cross-section study according to the stroke checklist under the supervision of Professor Dr. Saira Afzal. So the abstract is in the background. Quality of life is a growing area of interest in dementia research. However, it remains a controversial topic. This study aimed to determine the quality of life of people with Alzheimer's disease and investigate the factors affecting the patients and caregivers' quality of life scores. In methodology, it is a cross-section study design and a total of 98 home dwelling persons with Alzheimer's disease and their primary caregivers were recruited in the study. Sociodemographic characteristics and quality of life scores, activities of daily living, instrumental activities of daily living, mini mental state examination score, neuropsychiatry intervention, and uh, neuropsychiatry intervention distress were determined to assess the relevant outcome. In the results, the patient's rating of their quality of life were higher than those of the caregivers. Caregiver education, patient's activities of daily living, and instrumental activities of daily living were associated with the patient's score on the quality of life in Alzheimer's disease scale. In conclusion, from a clinical point of view, the proxy-rated scores of quality of life cannot replace the self-ratings of the patients. This study suggests that both self and proxy-rated quality of life scores should be applied whenever possible, and the findings of this study should also be used to design caregiver education programs about the determinants of quality of life. So, according to the checklist, we first have to check whether the study has indicated the design with the commonly used term in the title abstract. Yes, the study design, a cross-section study design was mentioned both in the title and abstract. And then where we have to check provide in the abstract an informative and balanced summary of what was done and what was found. The abstract had provided a balanced and informative summary of what was done and what was found. The next is the introduction. And in introduction, it has mentioned that Alzheimer's disease is the most common type of dementia and it is an important health problem in aging populations. Although the quality of life is a growing area of interest in dementia research, it remains a controversial topic. Measuring the quality of life of persons with Alzheimer's disease is a controversial issue given that the disease progresses with cognitive impairment. Several researchers have reported that persons with Alzheimer's disease have limited quantification of quality of life due to their cognitive impairment and non-cognitive symptoms such as depression and psychosis. On the other hand, patients should be the main source of information about their own lives, and the evidence indicates that persons with Alzheimer's disease can also comment on their own quality of life. For this reason, researchers are searching for ways to measure the quality of life meaningfully and accurately in persons with Alzheimer's disease. Most measures were based on proxy assessment with questionable validity for people with mild to moderate dementia. The best research measure was the quality of life in Alzheimer's disease scale that has two parts, that is the quality of life in Alzheimer's disease self-rating scale and the other is the proxy rated scale. The factors associated with the quality of life in Alzheimer's disease with the quality of life in Alzheimer's disease by self and proxy ratings have been reported in many research studies. However, none of them have used a Turkish sample. Researchers should consider that quality of life in Alzheimer's disease can have cultural differences. In addition to this, improving the quality of life is an important focus of various therapeutic interventions as an outcome measure to evaluate the interventions for Alzheimer's disease. Therefore, this study aimed to investigate the mutual relationships among cognitive impairment, behavioral symptoms, functional abilities, and quality of life as validated in persons with Alzheimer's disease and their proxies, as well as to identify the factors affecting self and proxies quality of life ratings. So, according to the checklist, in background or rationale, we have to explain the scientific background and rationale for the investigation being done. In the introduction, background is given, but it is not well explained. The rationale too is given, but is not clearly and well elaborated. And in the objectives, objectives are clearly defined. Then the methodology in the participant section, the study has mentioned cross-section and correlation study design, and the sample selection was conducted using non-probability convenience sampling, and a total of 98 diets of persons with mild to moderate Alzheimer's disease who were all home dwellings as well as the primary caregivers were recruited in the study. Then they have described the inclusion and exclusion criteria. Then there is a questionnaire. The farm was prepared to obtain the socio-demographic information such as gender, age, years of education, caregiving period, and relationship of persons with Alzheimer's disease and their caregiver. It was filled by their caregivers. First outcome here is the quality of life in Alzheimer's disease. This scale is available in two parts, as I have already mentioned, that is the proxy related and the self-reported. Self-reported was completed by the patients and proxy-related was completed by the caregivers. It is a 13 domain scale and each domain is rated as fair, good, excellent, and total score ranges from 13 to 52. And a high score indicates good quality of life. It has they have given their measurement scale, and then for comparison, the scores are calculated separately by self-reported and proxy ratings. The total score is rating by multiplying the score obtained through the answer of the patients by 2, adding the score of caregivers, and then dividing the answer by 3. Then the next outcome here is the clinical dementia rating scale. They have also given their measurements, that is 0 to 3, with no dementia, questionable dementia, mild dementia, moderate dementia, and severe dementia. The next scale is mini mental state examination. The scale is also given, and the total score ranges from 0 to 30. Our low score indicates high cognitive impairment. Then is the activities of daily living. Then the neurosciety inventory, and its score ranges from 0 to 144, with high score corresponding to severe behavioral disorders. Then is the neurosciety inventory distress. Its score ranges from 0 to 60, and a high score indicates a high level of perceived distress. Procedure. The study was conducted between June 2017 to June 2018 at a dementia outpatient clinic in the west part of the Turkey. The data were collected during the follow-up of patients at the outpatient clinic. The administration of the questionnaire lasted for 25 minutes. Caregivers filled the scale by themselves, considering the quality of life in Alzheimer's disease they care for, and for the person with Alzheimer's disease responded to questions about their quality of life by verbally. They have given the sources of their data collection. Then in the statistical analysis, all statistical analysis were performed using the FCPS version 22. The Shapiro-Wilk test was used to verify the normal distribution of variables. The parametric variables were described by their mean and standard deviation. Non-parametric variables were described by their median and interquartile ranges. For quality of life in Alzheimer's disease score, the average of self-reported and proxy scores were compared using the student's t-test, and then the correlation analysis were performed to clarify the relationship among cognitive impairment, behavioral symptoms, functional capabilities, caregiver distress, and quality of life. The stepwise forward multiple linear regression analysis were performed to identify the optimal model of predictors that explain the outcome variable of interest. For all analyses, the level of statistical significance was set at p-value of less than or equal to 0.05. So according to the checklist, we have to check whether they have mentioned the study design earlier. Yes, they have mentioned the study design, that is the cross-section study and correlation design. And then in the setting, we have to describe the setting, location, relevant dates, including periods of recruitment, exposure, follow-up, and data collection. They have mentioned the setting, that is the dementia outpatient clinic, and the data were collected during the follow-up of the patient at the outpatient clinic. Location is in the west part of the Turkey. They have not specified which cities or which provinces of Turkey, but they have mentioned in the west part of Turkey. Then in the dates, the study was conducted between June 2017 to July 2018 at the outpatient clinic. Then next is the participants. We have to give the eligibility criteria and the sources and methods of selection of participants. The study has mentioned the inclusion and exclusion criteria, but the sources and methods of selection of participants are not given. Then the variables. We have to clearly define all the outcomes, exposure predictors, potential confounders, and effect modifiers, give diagnostic criteria if applicable. Outcomes are defined, for example, quality of that is in the studies are the quality of life in Alzheimer's disease, clinical dementia rating scale, mini mental state examination, activities of daily living, neurosciety inventory, and neurosciety invented distress. While the exposure predictors, potential confounders, effect modified, and diagnostic criteria are not defined in the study. Next, the data sources and measurement. For each variable of interest, give source of data and details of methods of measurement. Describe comparability of assessment methods if there is more than one group. For variables, that is quality of life in Alzheimer's disease, CDR scale, MMSC, ADL, NPI, and NPI distress, methods of assessment are given. They have given their scale from 0 to 3, 0 to 5, etc. While the socio data are sources of the data are patients and their proxies. They have mentioned that quality of life in Alzheimer's disease proxy related will be filled by the proxies, and self-reported will be uh, filled by the patients verbally. While the comparability of assessment is given for quality of life in Alzheimer's disease. While the no bias has been addressed in the study, and in the study, it is not explained how the study size is arrived. Only sample size of 98 diets is given. And for quantitative variables, explain how the quantitative variables were handled in the analysis. If applicable, describe which grouping was chosen and why. In the study, parametric variables were described by the mean and standard deviation, while the non-parametric variables were described by the range and interquartile ranges, and groups described as patient and their proxies. In statistical methods, describe all the statistical methods, including those used to control for founding. In the study, they have mentioned that the Shapiro-Wilk test will used to verify the normal distribution of variables, while the correlation Pearson analysis were performed to clarify the relationships among cognitive impairment, behavioral symptoms, functional abilities, caregiver distress, and quality of life. The stepwise forward multiple linear regression analysis were performed to identify the optimal model of predictors that explain the outcome variable of interest. Then describe any method used to examine subgroups and interactions. For the quality of life in Alzheimer's disease scores, the average of the self-reported and proxy scores were compared using the student's t-test. Then explain how the missing data was addressed. Missing data was not addressed in the study. If applicable, describe analytic methods taking account of sampling strategy. Sampling selection was conducted using non-proprietary convenience sampling, while no information about the sampling later in the study. Now coming towards the result section, in the study it is mentioned our total 98 home dwelling patients were included, and the table 1 presents the socio-demographic and the clinical characteristics of the study population. Comparisons of the total quality of life Alzheimer's disease scores between patients and caregivers revealed a statistical significant difference, that is the t-value of equal to 64.50 with a p-value less than 0.001. The patients rated a higher quality of life than the caregiver group. No statistically significant difference was observed between quality of life assessment of patients who were cared for by the spouses and children with a t-value of equal to 0.801, p-value equal to 0.090. Self-reported quality of life score was the only socio-demographic variable that showed correlation with the caregiver education. This study also aimed to determine the most important predicting variables that explain the largest proportion of variance of self-reported and the proxy-related quality of life. The detailed results are shown in Table 3. Analysis revealed that the caregiver education years ADL, instrumental ADL explained 12% of the variance in self-rated quality of life, whereas caregivers education years ADL, IADL, MMSC, NPI, and NPI distress explained 26% of the variance in proxy-related quality of life in Table 3. So according to the checklist, we have to check whether the the study has reported numbers of individuals at each stage of study. For example, numbers potentially eligible, examined for eligibility, confirmed eligible, including the study, completing follow-up, and analyze. The study has not addressed these points. It has only mentioned a total of 98 home dwelling patients were included, while no other information how these all were collected. Then we have to mention the discovery data, that is the give characteristics of study participants, e.g. demographic, clinical, social, and information of exposures and potential confounders. Characteristics of study participants, e.g. demographic, clinical, social, are given in the table 1, while no information of exposure and potential confounders are available in the study. Then we have to indicate the number of participants with the missing data for each variable of test. It is again not mentioned in the study. Then for outcome data report, numbers of outcome events are summary measures, where these are outcomes are given in the tables 2 and 3. Then in the main results, give unadjusted estimates and if applicable, confounder adjusted estimates and their precision. Make clear which confounder were adjusted for and why they were included. It is not described. For all analysis, they have used the level of significance set at p-value of less than or equal to 0.05. Give reason for non-participation at each state. It is again not addressed. Consider use of flow diagram. They have not used any flow diagram. Then in other analysis, they have to report other analysis done, if, for example, also groups and interaction and sensitivity analysis. Uh, Analysis of groups were done only for the self-related quality of life and proxy-related quality of life. Then come towards the article, that is the discussion part. In this cross-sectional and prospective study, the caregivers education, activities of daily living, and instrumental activities of daily living of the person with Alzheimer's disease were associated with the quality of life in Alzheimer's disease in self-reported. Additionally, minimator state examination, NPI distress were associated with the quality of life in Alzheimer's disease proxy-related scores. Our analysis show no difference in terms of the gender of the informal caregiver as stated by the uh, Romhild et al., Suchuman et al., and Martai. Uh, they, in this study, they are in this part they are discussing their results with the other relevant researches. However, this result were different from the findings of the Kondi Sala et al. In the current study, the relationship with the informal caregiver showed no influence on patient with Alzheimer's disease, similar to the findings of Hong et al. And Romhill et al., unlike the findings of Robertson et al., Suchuman et al. Know the differences between the self and proxy quality of life of Alzheimer's disease. Patients rated a significantly higher quality of life than caregivers, which is in accordance with the results of the previous studies. Now, the factors affecting quality of life in Alzheimer's disease, factors affecting quality of life in Alzheimer's disease in self-reporting. According to the results of this research, caregiver education and the functional level of patients affect their self-reported quality of life. Unlike this study result, Rommel et al. And Marta et al. Conducted that caregiver education is not related to the quality of life. Factors affecting the quality of life in Alzheimer's disease proxy related. Caregiver education years, functionality, cognition, behavioral symptoms, and distress affect proxy related quality of life, similar to the findings of the study that is conducted by the Sosa et al. Regression analysis. Overall, our fitted regression models were quantified 12 to 26% of the observed variance of the difference between self-reported and proxy rating. Therefore, other unknown factors influence the difference between self and proxy rating, and they were not addressed by the data of analysis. Conclusion. From a clinical point of view, the proxy rated quality of life rating cannot replace the self rating of the person with Alzheimer's disease. This study stressed that both self and proxy rated quality of life ratings should be applied whenever possible, and the findings of this study should be used to design caregiver education programs about the determinants of quality of life. Several limitations have to be considered in our study. First, the findings are specific to the patients with mild to moderate Alzheimer's disease and who live in their home. Therefore, the results cannot be generalized to people with severe Alzheimer's disease or institutionalized patients. In addition to the emotional aspects of care, such as depression and anxiety, were not evaluated. Future research may focus on quality of life changes over time. The quality of life of late stage person with Alzheimer's disease and the factors that affect the patients and caregiver quality of life rating must also be determined. Funding. They have mentioned that this study was financially supported by the researchers. Now coming towards the checklist. In the key results, the study has to summarize key results with reference to the study objectives. They have given their key results with respect to the study objectives. And in limitation, discuss limitations of the study, taking into account sources of potential bias are imprecision, discuss both direction and magnitude of any potential bias. The study has discussed its limitation that it is limited only for the patients of mild and moderate Alzheimer's disease and those who are living in their home. while the sources of potential bias are the imprecision are not addressed. In interpretation, study has to give a cautious overall interpretation of results considering objectives, limitation, multiplicity of analysis results from simultaneous studies, and other relevant evidences. The study has mentioned its interpretations with the similar studies, and they also have discussed them. Then is the generalizability. The study has to discuss the generalizability, externality of the study results. Given that the study has discussed its generalizability, that is, uh, the results cannot be generalized to people with severe Alzheimer's disease or institutionalized patients. And in the last is the funding. Give the source of funding and the role of funder for the present study, and if applicable for the original study on which the present article is based. The study has mentioned is funding source that was supported by the researchers themselves. Thank you very much for today. And this is a link of the article of today's critical appraisal. And this is our YouTube channel. Here all our lectures are uploaded. You can go there and watch them if you want.
Thank you very much, Dr. West. Very nice presentation, and I am very glad that with time this has become a very good presentation, and very important points have been discussed in full detail. As we have discussed in previous slides, there were certain important things that were missed, but in this today's presentation, we have been looking at each and every point with great clarity. I would like you to please give the strengths and the limitations of whole of this research in 2 slides at the end, and take home message that would further increase the impact of this presentation. As you have told us about the important limitations in discussion, these were the limitations that were present in the discussion, that it is present in certain specific patients that were in home. However, what were the strengths of this overall research, and what are the weaknesses that are further can be further analyzed in future? One of the thing that I have noted is in methods, it was the Shapiro Wilk test that was applied for normality. So one of the strength can be that the normality has to be assessed by different methods, QQ plot and statistical test and biographical methods, and that would increase the strength of this study. The second important thing is about variables. Again, the variables that were analyzed, as you have shown in our results section, again further comparisons, because the sample size, if it is increases, then the number of the variables along with the p-values, they would have more influence. Moreover, the sources of data, as you have already said, that there were different sources, and when even the correct answer was not present, then proxies were there. So would you please highlight what are the other things that can be done in order to make this study a very strong study?
Yes, ma'am. In this study, I noticed many weaknesses that if we go to the introduction section, they have not given their strong background of the study about the Alzheimer disease or whether the quality of life measuring scales, and they have not well or defined their rational well. It can be improved in the introduction section.
Okay, another good point or the strength of the study is that it is done in the community, and number second important point is it has picked very early disease, so the prevention can be done at a proper place. Third strength of the study is that they have utilized very good methodology. Inclusion exclusion criteria was good, and they have utilized a certain statistical test in order to come to the conclusions. and they have given the mental state examination scores and mini state mental state examination, etc., etc. And another very important strength is that there is minimal conflict of interest because the researchers funded themselves, so there are no other sources like companies and industries that are involved, so the results are having less chances of any conflict of interest. So these are some of the strengths that come while you were presenting this. So we would stop this presentation here, and I would request all the students to rejoin the link for further discussion. And this is my input in this slide. Very well done, Dr. Awais. You always made me very proud of your hard work and commitment to learning. Thank you very much.
Okay, ma'am, thank you very much for your marks. We are join the class again. Thank you.